Welcome to Raaonline. I'm Dr. Nahid Azhar, anesthesiologist from Madras Medical College. In our daily practice, we use IV anesthetics quite frequently to induce and maintain our patients. And we know how these drugs act, on which receptor they act, and how do they produce anesthesia, what are their side effects. And all these are explained by the pharmacodynamics of anesthetics. There's another component of these drugs called as pharmacokinetics. And today we are going to examine the pharmacokinetics of IV anesthetics, and we're trying to figure out if the knowledge of pharmacokinetics of IV anesthetics can help us deliver safer and better anesthesia to our patients. So the search for an ideal IV anesthetic continues. We are looking for certain features that will make our anesthesia safe, and the ideal IV anesthetic hasn't yet been discovered. But while waiting for it, we continue to use IV anesthetics every day in our clinical practice. The most commonly we use it is as bolus doses to induce anesthesia. For example, when you induce anesthesia, you give patient propofol in a dose of about 2 mg per kg. When you give this injection intravenously, you will find that in less than 1 minute, the concentration goes to a peak, which is much above the therapeutic range that is actually needed to produce anesthesia. And then it quickly drops down. And you will find somewhere between 6 to 8 minutes, it comes down below the therapeutic range, where the anesthesia will be ineffective. So it stays in the therapeutic range only for a short duration of time. The requirement of the drug in the blood to produce anesthesia is different for different surgeries. Taking propofol as an example, for a major surgery you need propofol about 4 to 6 microgram per ml in the blood. But for minor surgery it comes down to about 2 to 4 microgram per ml. For sedation it is 1 to 2 microgram per ml. And the patient will wake up only when the serum propofol concentration falls to about 1 microgram per ml. Similarly, if you look at thiopentone, for major surgery you need about 10 to 20 microgram per ml. For minor surgery you need about 6 to 20 microgram per ml. Sedation is about 4 to 8 microgram. And wake up occurs when thiopentone concentration falls below 4 microgram per ml. For all the IV anesthetics, these values are well known. Some people maintain anesthesia by giving multiple boluses of the same drug. For example, they keep giving boluses of propofol, 20 or 30 mg every 5 to 10 minutes. What happens when you give a bolus? The concentration goes up, then immediately it falls down. Then you give another bolus, it goes up and comes down. So you basically produce a yo-yo effect of concentration of propofol in the plasma. So when you give an IV bolus, you will find that the concentration goes up above the required concentration. It may lead to hypotension that you don't want to see. Then it quickly falls down and goes down below the therapeutic range. The problem is when it goes down the therapeutic range, the patient experiences a hiatus in anesthesia. During this period, the patient will have inadequate anesthesia, and if you continue to operate him during this period, he might have either awareness or undesirable side effects of continuing surgery with anesthesia not being adequate. Why not just give up the bolus doses and give an IV infusion? That can be tried. But if we started an IV infusion without giving a bolus dose, to reach the serum therapeutic concentration effective to produce anesthesia, you need to wait about 15 to 20 minutes, which means you will start an IV infusion. You will wait about 15 to 20 minutes before the patient can actually be operated on. So 15 to 20 minutes of time is basically wasted. So can we combine both of them? Yes, we can. We can give a bolus, immediately follow it up by an infusion of the same drug, say propofol. So the propofol bolus that you gave produces a peak in concentration. By the time it comes down, the infusion of propofol has picked up the concentration. Therefore, you will find that right throughout the procedure, from the time you started the bolus, the concentration is effective to produce adequate anesthesia and to do surgery. So a bolus primed constant infusion seems to be the best method of using only intravenous anesthetics to produce and maintain anesthesia. Now each anesthetic drug has its own potency, which is called as effective dose 50 or is called as C50. C50 is defined as the amount of drug required to elicit an effect in 50% of the patients. Now IV anesthetics have got different endpoints like loss of consciousness, EEG depression, lack of response to incision, and each of them have a different C50. Once again, taking propofol as an example, propofol C50 for loss of consciousness is about 2 to 3 microgram per ml. But for EEG depression, you need a higher concentration. We need propofol in 3 to 4 microgram per ml. And to obtain the response to incision or painful stimuli, propofol should be much higher at about 4 to 8 microgram per ml. Likewise, if you look at thiopentone, loss of consciousness at 8 to 16 microgram per ml, EEG depression at 15 to 20 microgram per ml, and lack of response to incision at 35 to 40 microgram per ml. Even the IV narcotics have got their own C50 values. So, a same drug can produce different effects, and for each effect, the same drug has got a different C50 value. I'm going to be using fentanyl as an example. So, this is your C50 value, 50% it will be effective. So, if you take the C50 for analgesia in fentanyl, it's only about 2 nanogram per ml. But ventilatory depression occurs at 4 nanogram per ml. And lack of response to laryngoscopy occurs at 15 nanogram per ml. And changes in EEG occur at 20 nanogram per ml. Therefore, we understand that the same drug for different endpoints has got different C50. This is good for both narcotics as well as IV anesthetics. Why do we need to understand pharmacokinetics? Once again, taking propofol as an example. We know that propofol acts on the GABA receptors that are present in the brain. And at the GABA receptor in the brain, we need propofol only in a concentration of about 1 to 3 microgram per ml. To produce this concentration in the brain, in the plasma, we need a propofol concentration of about 4 microgram per ml. And to achieve this, we give a dose of propofol of about 2 to 3 milligram per kg, which is 3000 microgram per kg. So, we give as high as 3 microgram per kg, when actually in the brain, we need only 1 to 3 microgram per ml. So, this high dose that we have injected intravenously, why does it not go completely to the brain? Why does very little of it go to the brain? And where does the rest of the drug go? To understand this, we need to understand the pharmacokinetics of drug. And this pharmacokinetic knowledge helps us to design an appropriate drug regime for a patient. So, pharmacokinetics is defined as a mathematical relationship between drug dose and drug concentration over time. Or, it tells you how a drug moves through the body over time after it has been injected into the body. The pharmacokinetics consists of different areas. The first area is called as processes. It consists of absorption, distribution and redistribution, metabolism and excretion. This is called as the ADME scheme. The second area is explained by lot of equations that can measure accurately or calculate accurately and tell you what the values will be in the various parts of the body. These pharmacokinetic measurements that can be explained by equations are called as metrics. These equations are quite complex and are out of the purview of this lecture, so we're just going to skip it. Finally, based on the measured and analyzed data, we can now construct models of the human body that are able to explain what happens to a drug when it's injected intravenously or taken orally. This is called as modeling. All these go together to produce our understanding of the pharmacokinetics of drugs. First, we look at distribution.